All right, if you're looking to lock down one of the absolute highest yield board favorite mnemonics in all of rheumatology, well, you're in exactly the right place. Today, we're going to completely demystify limited cutaneous systemic sclerosis.
Picture this. You're on the wards and a 44-year-old female patient comes in with a pretty interesting story. She says that whenever she goes out into the cold, her fingers go through this bizarre color change. First, they turn stark white, then they turn blue, and finally, they become this bright, painful red. And to top it all off, for the last month or so, she's been having a really hard time swallowing her food. So, what exactly is the diagnosis here? Keep this patient in the back of your mind because we're going to solve her case together.
Salam, welcome to A Little Push, 5 Minutes Medical Mnemonics. I'm super thrilled to be your guide through today's explainer, where we take those super complex medical concepts and make them incredibly easy to grasp and, more importantly, to remember.
Okay, so first things first, what are we actually dealing with here? Systemic sclerosis, or scleroderma, is a connective tissue disease where your body deposits abnormal collagen right into the skin and organs. Now, it comes in two main forms, but today we're strictly focusing on the limited variant. The secret key to remembering the clinical features of this limited form, which used to be and honestly still is commonly known as CREST Syndrome, is, you guessed it, the mnemonic CREST. These 5 letters give us the 5 distinct physical findings that'll help you instantly differentiate this limited variant from the much scarier, more aggressive diffuse form. Let's break them down.
Kicking things off with our first letter, C is for calcinosis, specifically calcinosis cutis. What you're going to see and actually feel in these patients are these firm, yellow-white calcium deposits. Now, these aren't deep in the bone. They're ectopic, meaning they develop right there in the skin and subcutaneous tissues. When you examine your patient's hands, you'll often feel these as small, hard, palpable nodules, usually right in the pulps of their fingers. It's a really distinct physical finding.
Moving on to R. R is for Raynaud's Phenomenon, and this beautifully explains our patient's crazy finger colors from that introductory case. Raynaud's is basically an episodic vasospasm of the small arteries that supply the fingers and toes. It's almost always triggered by cold weather or emotional stress. And you absolutely need to know the exact sequence here. First, the fingers turn white due to ischemia, a complete lack of blood flow. Then they turn blue from hypoxia as the trapped oxygen gets used up. And finally, when that spasm breaks, they turn bright red due to reperfusion. So remember, white, blue, red. Next up, we have E, which stands for Esophageal Dysmotility. This right here answers the second part of our patient's main complaint, her difficulty swallowing. In this syndrome, there's a fundamental dysfunction of the smooth muscle and the lower esophageal sphincter. Because the esophagus just isn't contracting the way it should, food literally gets stuck, leading to dysphagia. Plus, because that lower sphincter is totally weak, gastric acid just freely washes right back up. So it's super common for these patients to come in complaining of severe chronic acid reflux. Let's move to S. S is for sclerodactyly. If you break down the word, the root sclero means hard and dactyl means digits. So this is the localized thickening and tightening of the skin, specifically on the fingers and toes. The skin gets the shiny, waxy look to it. And as the fibrosis progresses, it physically limits joint movement. It literally pulls the digits inward, giving the hands this very characteristic, tapered, almost claw-like appearance. The skin simply becomes way too tight for the fingers to even straighten out. And finally, T is for telangiectasias. These are small, abnormally dilated blood vessels right near the surface of the skin. They create these focal, little red marks or spider-like patterns. In patients with limited cutaneous systemic sclerosis, you'll typically spot these marks scattered across their face, on their hands, and sometimes even inside their mouth on the mucous membranes. And there you have it. That completes the classic clinical picture of the CREST mnemonic.
Okay, so we've officially mastered CREST, but why does this actually matter so much clinically? Let's pivot for a second to some extremely high-yield clinical correlations. It is absolutely vital that you can differentiate limited from diffuse scleroderma. Limited disease, which is our CREST syndrome, primarily affects the skin on the face and distal extremities, basically staying below the elbows and knees. It generally has a slower, somewhat more benign clinical course. Diffuse disease, on the other hand, much scarier. It involves widespread truncal skin thickening and carries a way higher risk for early, life-threatening internal organ involvement. We're talking things like interstitial lung disease or a sudden renal crisis. Spotting those CREST features helps you categorize the patient's risk profile right away. Now, I want to share a massive exam secret with you. 96%. If you suspect CREST syndrome, you're obviously going to order an ANA screen, but you need something much more specific. Well, anti-centromere antibodies are incredibly specific for this condition. In fact, roughly 96% of patients with anti-centromere antibodies have the CREST variant. Compare that to the diffuse form, which is famously associated with an entirely different antibody, anti-SCL70. So remember, centromere is for CREST, SCL70 is for diffuse. That is a guaranteed point on test day.
So how do we actually help these patients? While there isn't a magic cure to reverse all the fibrosis, we definitely treat the symptoms aggressively. For that painful Raynaud's vasospasm, the board favorite way to reverse it is vasodilation. We use calcium channel blockers or CCBs, specifically things like nifedipine or amlodipine. And for the esophageal dysmotility and severe acid reflux, we aggressively manage that GERD with proton pump inhibitors to prevent nasty esophageal strictures down the road.
All right, you've absorbed the material beautifully. Now it's time to put your brain to the test with a quick rapid review. Here is your first question. Which highly specific antibody is associated with CREST syndrome? I'll give you a few seconds to lock in your answer.
Got your answer? The answer is anti-centromere antibodies. Remember that 96% statistic we anchored in earlier? Anti-centromere is literally the secret to locking down this diagnosis on any exam.
Okay, let's do one more just to make absolutely sure this is completely cemented in your brain. What class of medications is suggested to treat the Raynaud's component of this syndrome? Think about the mechanism we talked about. And the answer is calcium channel blockers, CCBs. Medications like nifedipine or amlodipine are your go-to drugs to promote vasodilation and stop that painful white to blue to red color change. Excellent job if you got that right. Well, you've completely conquered the CREST mnemonic and the absolute highest yield facts of limited cutaneous systemic sclerosis. By mastering these core concepts, you're building a rock-solid foundation that's going to serve you not just on your exams, but way more importantly, with your future patients. So keep reviewing, keep connecting those dots, and keep that momentum going. Until next time, salam.